Good afternoon, everyone. I'm Dr. Stephen Adams. I'm the medical director at APO Community Health Center. Um, we started out as an AIDS service organization in the mid-'80s. Actually, this is our 40th year. And we served only folks living with HIV. I began working there as medical director in 2008. 2012 is when PrEP was introduced. And so 2013, we opened up our practice. So not just folks living with HIV, but folks who needed PrEP. We had already been doing transgender care for our folks living with HIV. We were doing hepatitis C care for our folks living with HIV. And so we just opened our practice up to that group of folks. So now we have about 2,200 people that we care for. We have about 750 folks living with HIV. I have a very large transgender population, and then we have a large population of folks getting PrEP, and then primary care for largely an LGBTQ population. So today we're going to talk about what's different when you're taking care of folks who don't identify as heterosexual. And it really isn't all that scary, or shouldn't be. So what are some of the terms we're going to be using? Lesbian, gay, bisexual, transgender, questioning. That's kind of what the letters stand for. And then there's a host of other sexual orientations other than heterosexual. People define their own sexuality. And so there is this continuingly long list of ways that people identify other than heterosexual. Other terms you want to know: cisgender, you are the gender that you were born. You were assigned at birth. Transgender, you're not the gender that you were assigned at birth. Assigned female at birth, assigned male at birth. Top, the insertive partner in rectal intercourse. Bottom is the receptive partner. Top also refers to the chest area of transgender patients' chest anatomy. Bottom refers to their genital anatomy. MSM, men who have sex with men. So we'll see those throughout the presentation. So what are our patient care goals? Well, they're not really different than if we were taking care of, no matter where we are. Our patient care goals are going to be the same. Identify and manage health risks. In a diverse population of patients, health risk really is going to be dependent on blood pressure, cholesterol, how well you eat, how much you exercise, and then sexual practices. That's the piece that gets left out in most other practices. And that's the piece that I continually hear from students who rotate through APO. That's the piece they don't get to practice when they're in other rotations, is talking to people about their sexual health, because it predicts lots of risk. So we want to manage all of those health risks, including sexual health risks. And it's not going to be different than other patients, except that especially in our practice, we focus a lot on sexual health. And then caring for transgender patients is the same as caring for cisgender patients who need hormone replacement. So you have a woman who comes in and for whatever reason, she had to have a hysterectomy and an oophorectomy in her 20s, and you're going to replace her estrogen. You're going to do that the same way that you would do it for a transgender female. Except in the transgender female, you're also going to suppress their testosterone production. And then the piece that you have to remember is that the body parts may not be the same. And you have to think about what body parts are present when you're taking care of transgender folks. Risk identification, family history, patient medical history. Do they have high blood pressure? Are they tachycardic? Or do they have low blood pressure? What their lab results are, and their sexual practices. So how are you going to identify sexual practices? What you don't want to do is make people feel bad about their sexual practices. So don't ask, are you having sex with men or women, especially in a diverse population, because I may only have sex with transgender males. My risk of having sex with transgender males is different than if I'm having sex with cisgender men. So asking if you have sex with people who are male or female may not get you the answer that you want. Don't ask how many sexual partners in the past year. Making people come up with a number can make them feel bad about their sexual practices. What you need to know is, do you have one partner or do you have more than one partner? Do your sexual partners have penises, vaginas, or do you not care? Do you have sex with both penises and vaginas? Do you have receptive vaginal or receptive rectal sex? What parts of your body are you using for sex? Because if you're using a body part for sex, that's a place that we're going to have to test for STIs. You share sex toys or fingers. All of those things increase your risk if you have more than one partner. So you're taking care of a group of lesbians. Their risk for cervical cancer is incredibly low. All of the sexual risks go way up when you put a penis in the equation, and it goes way down when you take the penises away. If you're in a stable relationship, you have one partner, you've had normal pap smears for 3 years, or 3 times in a row, do you need to repeat their pap smear if they have the same partner and they don't have HPV? Of course not. You wouldn't do that in a married couple. If you have a stable married couple and she has normal pap smears and they're monogamous and she has normal pap smears, you're not going to continue doing those pap smears. You don't have to. That's in the guidelines. If they have multiple partners, if they're sharing sex toys, they're at increased risk of HPV, which puts them at increased risk of cervical cancer, unless they've been vaccinated. And they're at increased risk of STIs. And there's no change to mammogram screening in a lesbian couple. MSM, stable relationship, one partner, normal anal pap. You've done 2 or 3, they're normal, the HPV is negative, they're at no additional risk. Okay, you're gonna stop screening them. If they have multiple partners or if they change partners, you're gonna repeat their STI screening, you're gonna repeat their anal pap smear, their HPV screening. If they have multiple partners and you're doing routine STI testing, we do that every 3 months. Routine screening in an MSM population includes syphilis, HIV, 3-site gonorrhea and chlamydia. So 3-site is oral, rectal, and genital. And why do we do 3-site testing in an MSM population? Because if we don't do 3-site testing, we miss 70 to 80% of active STIs. In an MSM population, the pharynx and the rectum are the most likely places to find STIs. And yearly we do a Hep C. Annual anal pap for those folks who are at risk. HPV vaccination can be given up to age 45. It's not in the guidelines, but it is in the FDA package insert. And so in an MSM population, their risk of anal cancer is 40 times higher than the general population because of HPV. And so for all of my MSMs who have not been vaccinated, we get them vaccinated. MSMs should be immune to hepatitis A and hepatitis B because of the oral fecal transmission of hepatitis A. MSMs are at higher risk of Hep A than the general population. And CDC came out with a new recommendation last year. Everyone should be screened for hepatitis B immunization. And if they're not immune, they should be revaccinated because our new vaccine is much better. Other groups. So you're going to screen for STIs and PAPs, anal PAPs, regular PAPs, based on sexual activity and body parts that are used for sex. Many transgender men don't use their vagina for sex. And if they don't use their vagina for sex, they're not at risk. And if you can get a pap smear that shows that their HPV is negative, you're probably going to be okay not doing regular paps in that population. If you have breasts, you need mammograms, whether you're assigned male at birth or assigned female at birth. If you have breasts, you need mammograms. If you're a trans male and you don't have breasts anymore, you don't need mammograms. If you have a cervix, paps are needed. If you have a prostate, you need to consider whether or not you need to do PSA screening. So those are all things that you need to think about when you're dealing with a diverse population. Yeah. So for your patients who are at risk of HIV, PrEP, pre-exposure prophylaxis, decreases the risk of HIV based on adherence and the type of medication that you're using. So all patients who are at risk, sexually active persons, multiple sex partners, any person with a recent history of an STI. Is the risk factor for gonorrhea different from risk factors for getting HIV? The answer to that is no. Just had a patient, new diagnosis of HIV yesterday, who was in the ER a month ago, didn't feel well, had a little dysuria, and they did syphilis, gonorrhea, and chlamydia, but they did not do an HIV test. And he actually had acute HIV at the time he was seen. But they did not do an HIV test, despite the fact that they knew he was gay and he had an STI. He had symptoms of an STI. But anyone with a recent history of an STI has been having sex with someone who gave them the STI, who also is at risk for HIV. You have to test for all four. If you're not testing all four and 3-site gonorrhea, chlamydia, or whatever body parts they are using for sex, you're not doing the patient a service. And if you're IV drug user, obviously your risk is higher for HIV. MSM black males have a lifetime risk of HIV of 1 in 2, 50%. If you're a white MSM, your lifetime risk is 1 in 11. And currently only about 40% of people at risk for HIV are taking PrEP. Federal government just slashed the prevention budget. And so we'll see that number fall and the number of new cases of HIV go up in the next few years. PrEP, how do you do PrEP? When the students come through, we'll see a bunch of patients and then we'll go in and we'll see a PrEP patient. I'll walk out of the room and I'll go, oh my Lord, that was just so difficult. And the students look at me and they give me this funny look and they're like, well, that was the easiest visit we've had all day. I'm like, well, yeah, it was. Once you know how to do this, it's really easy. It's really about just setting up with your lab what tests you need done, having the patients come in, talk to them about what the meds are, and hey, are you using condoms? Are you having safe sex? Your STIs are negative. Let's work on the safe sex part. So we have 4 meds for PrEP. Truvada, which is now generic, emtricitabine TDF, Descovy, emtricitabine TAF, Apretude, which is injectable cabotegravir, Truvada, and Descovy or oral medications taken daily. Truvada you can take intermittently. Apretude, injections every 2 months. Yaztugo, which is injectable lenacapavir. It's a new class of HIV med. It's a capsid inhibitor. It's a 2 sub-Q injections every 6 months. So if you're on oral meds, you're going to get STI testing every 3 months. If you're on Apretude, you're going to get STI testing every 4 months. So it coincides with your every 2-month injections. And lenacapavir, because it's every 6 months, we're going to try and get you in every 3 to 6 months for STI testing. I am not currently using lenacapavir in our clinic, but I would prefer they come in every 3 months. What tests are you going to get? RPR, HIV. If you're doing an injectable medication, you're going to test HIV RNA. If you're doing oral medications, you're going to do an HIV antigen antibody test. And the reason for that is when they did the registrational trial for Apretude, folks who were only using the antigen antibody test, and they found folks who became HIV positive, and then they looked back at stored samples from prior blood draws, and there was 4 people who had new HIV who had positive HIV RNAs 2 to 6 months prior to their HIV antigen antibody test becoming positive. So the current recommendation is if you're on an injectable med, you get an HIV RNA test with every injection and every STI testing. And if you're on oral meds, you get an HIV antigen antibody test. Truvada, you can give to everybody. People assigned male at birth, people assigned female at birth. Descovy is only for folks who were assigned male at birth. There have been no studies in people assigned female at birth. There was one arm of the lenacapavir study that did use Descovy in a assigned female at birth population, but that arm was not designed to show that Descovy was non-inferior to other methods, and so they can't use that study to get it FDA approved. Truvada, if you were assigned male at birth, what we know from the original studies looking at adherence, if you were male and you took 4 doses of Truvada a week, it worked just the same as if you took 7 doses a week. We also know from the similar studies done in people assigned female at birth, you must take Truvada 7 days a week, or it doesn't work, because concentrations of tenofovir in the vagina are significantly lower than concentrations in the rectum. And so assigned female at birth, you must take oral medications every day. New from last year, the guidelines are now back up on the CDC website. They were not up last year when I gave this lecture. UCSF is a great place. They have tons and tons of resources for HIV, PrEP, Hep C. I use their website all the time. It's the National Clinician Consultation Center, NCCC. And you can get tons of information. Send them a question. Some expert from there will call you back and give you an answer. DoxyPEP. The study came out about 1.5 years ago now. The study was done both in people assigned male at birth and people assigned female at birth. The adherence among people assigned female at birth was incredibly low. And so they showed no efficacy of DoxyPEP in that group. So currently it's only recommended for people assigned male at birth. Do I prescribe it to people who were assigned female at birth as a potential safety net measure? I do, but I don't have the evidence to show that it works. So what is DoxyPEP? Doxycycline, 200 milligrams, so that's 200 milligram tablets, taken within 24 to 72 hours of unprotected sex. And it decreases your risk of gonorrhea, chlamydia, and syphilis by 60 to 70%. Actually, 80% for gonorrhea and chlamydia, and 60% for syphilis. So that's like pretty amazing. And I tell all my patients 60% is really not 100%. And so we're going to continue to encourage you to use condoms. This does not relieve you of the need to have safe sex practices. There is a current study going on right now. If you're going to take it daily, rather than taking 200 milligrams, which is going to be really hard on your stomach, just take 100 milligrams every day along with your PrEP, and it is going to work as well. CDC does have an informational page on their website, as does UCSF. Transgender care. So this really is not difficult. And students, after seeing 1 or 2 patients in our clinic, they're like, Oh, yeah, this is not so hard. So you want to just, in male to female, you want to suppress testosterone. They want to get rid of those masculine features. So you're going to put them on spironolactone. In our clinic, we start at 100 milligrams. We usually have them take a half a tablet for a week or so just to get used to it, and then increase to a whole tablet. You can go up to 200. Actually, the max dose is 400. I've never had anybody need more than 200. You can use finasteride. Finasteride blocks the action of testosterone. It does not stop testosterone production like spironolactone. And you're going to use finasteride at 5 milligrams a day. And most people who don't tolerate spironolactone do very well on the finasteride. So you're going to then start some estradiol to start feminizing the patient. The cheapest way to do that is oral tablets. We have people dissolve them in their mouth, so you bypass the liver first pass degradation of the estradiol, so they get higher blood levels. We start at 4 milligrams, which is 2 tablets a day. And I have folks who are on up to 10 milligrams a day. Injectable estradiol as valerate or cypionate. The difference between the two is the oil that is used. One of them is a nut oil and one's not a nut oil. And so some folks are allergic to one or the other. Off the top of my head, I can't remember which one's which. Cypionate is the one that is most commonly used. And if you're allergic to that, then we switch to valerate. Nationwide, there is a shortage of both drugs. And so they're not available all the time. And so if you're on an injectable estradiol, it's not uncommon that you'll take it for 3 or 4 months and then the pharmacy will be unable to get more for you. It's given weekly. You can give it twice weekly. It's just a lot more hassle. A lot of transgender females, if you go onto their chats and their support groups, there's a lot of chatter about using progesterone to increase breast size and body fat distribution. And studies show that it probably isn't very effective. But the other part of the study is folks who are on progesterone and feel better, that it's something that does make life better for transgender females. And so if people want progesterone, I'm like, give it a try. May not work, may help you. If you feel better, we'll keep you on it. So when you start hormone therapy, what changes? So the first thing you're going to notice is breast growth. Once you have breasts, you're always going to have breasts. You stop taking your hormones, the breasts are going to stay. Reversible changes, because we're stopping testosterone production with spironolactone, testicles are going to shrink. Your erections are going to be fewer and less firm, may not be firm enough for intercourse. Hair growth slows and your hair gets finer. The amount of hair you have, once you have all that hair, it's there forever unless you get it removed. The skin gets a lot softer and you're going to see some body fat redistribution. All of those are reversible changes. You stop the hormones, all that comes back. Voices do not change. Once your vocal cords are the size they are, that's the voice you're going to have. You can have feminization surgery, which actually thins the vocal cords and raises your voice. And most folks just do vocal coaching to kind of make them sound more feminine. Female to male, you only need one drug. You just got to give them testosterone. You give them testosterone, they stop making estrogen. We use testosterone cypionate. It is the cheapest way to get testosterone. Pills are available. They're horribly expensive because they were just introduced about 2 years ago. We do have topical testosterone gel. It is a lot more expensive than injections as well. Starting dose for gel daily is 2 pumps. There is no direct correlation between how much testosterone you're getting as an injection and how many pumps of testosterone you're going to need. So if you're going to switch from one to the other, you just start at the starting dose and increase it until you reach the dose that you want. Permanent changes with testosterone. Your voice is going to get deeper. That's the first thing that happens. Your vocal cords thicken up. That's permanent. Clitoral enlargement, permanent. You're going to get more hair. And people are like, well, I just don't. I said, well, how much hair does your dad have? How much hair do your brothers have? Are they? That's the amount of hair you're going to probably get. So, and then in females to males, male pattern baldness. You got to look at your mom's family. You know, are they all bald? You gotta. That's probably what you're going to be if you keep on the testosterone. Reversible changes. Your skin gets more coarse, more oily. There is fat redistribution. Breast size does get smaller because of the fat redistribution, but not a lot. Your H&H goes up and your LDL goes up. Those are biologic related to testosterone changes. Monitoring. During the first year and until we have stable hormone levels, we follow up every 3 months. And then every 3 months if we make any changes to the regimen, just so we can keep tabs on making sure things are going well for patients. The goal hormone level is really not a number. The goal hormone level is the place where the patient feels that they look and feel the way they want to feel. You don't want them to have unsafe hormone levels. So for testosterone, you want to try and keep that below 1,000, and estradiol, keep it below 200. Normal range for testosterone in men goes up to about 1,500, and testosterone is about 220 in cisgender women, but we try and keep our trans folks more mid-range, so try and keep those kind of peak levels below 1,000 or below 200. If they're getting testosterone injections, they're going to have really high levels at the beginning, and then it's going to come down over the week. Same is true for estradiol. In our clinic, we measure the nadir. So we're looking at what those hormone levels are 5 or 6 days after their last injection. And what our goal is for testosterone, we want that low level to be about 500 to 700. For estradiol, we're looking at 120 to 140. Estradiol, most of those folks are on pills. And so those are daily pills, and we want them kind of mid-range that's for injections. If they're on pills, we want them near 150, 180, closer to that 200. They can take their pills the day before, not right before they get their blood drawn. If you're doing topical testosterone, don't put it on right before you come into the clinic, because your levels are going to be really high. We want to know what it is just before you put it on, or just before you take your pills. Transgender care monitoring, male to female, mammograms start at age 40 or 10 years after breast development. And then you're going to once they start, then you just follow the guidelines based on their age. So if someone starts transitioning, not as a teen, well, 18-year-old, they can transition at 18. You're going to start mammograms at age 40. If they transition at age 30, they're going to start at age 40. If they transition at age 50, you're going to start mammograms at age 60. Male to female need to consider prostate cancer screening. We don't have data on this. We expect data in over the next few years, but the reason we add this is because you want to consider the body parts that the patient has and what those screening guidelines are. Screening guidelines for prostate cancer are currently in flux because our treatment of prostate cancer our monitoring of elevated PSAs is changing. So as those guidelines continue to evolve, we'll need to consider what we need to do for our transgender females who have prostates. Male to female, we monitor both estradiol and testosterone. If someone has an orchiectomy, you don't have to monitor testosterone anymore. If someone's on finasteride, because finasteride only blocks the action of testosterone but not production, we generally don't monitor their testosterone levels, just their estradiol levels. We want to make sure their estradiol levels are therapeutic. Females to males, if they're at risk of pregnancy, if they're having sex with someone who can make them pregnant, they need birth control. Testosterone is not an adequate form of birth control. We recommend either a Nexplanon or an IUD. If you're transgender male and you have breasts and you're 40 years old, you're going to get a mammogram. And you're going to get mammograms until you have breasts removed. Pap smears are per guidelines and based on risk. For our transgender men, we use intravaginal estradiol for 2 weeks prior to the PAP. Otherwise, the PAP is going to come back as atrophic, because we've taken away their estradiol. And so all you're going to get is atrophic changes. But if you use the estradiol for 2 weeks, the cervix is going to look more normal. You're going to get an adequate pap smear, and it also makes it way less uncomfortable. Additional considerations, as folks are going through transition, a lot of times they're like, oh, this is taking so long. And I just remind them, puberty took a long time the last time. It's going to take about the same amount of time the second time. So you can't think that, oh, I started hormones, 6 months later, it's all going to be done. It just doesn't work that way. So they need to understand that this is a long process. And they're going to need a lot of support, especially today in the current environment. Being a transgender patient, they're just putting a big old bullseye on their back for getting discriminated against. And they're going to need support from family, friends, other trans patients. If they want any gender-affirming surgery, they are going to have to be in therapy. They have to see a counselor. There are no surgeons in this country, there are rare surgeons in this country, and none in the Midwest who will do gender-affirming surgery without a note from a behavioral health person. Many of our transgender folks have lots and lots of trauma. In that patient population, we have a very high rate of autism, which is interesting. If you're autistic, you're 70 times more likely to be non-heterosexual, identify as non-heterosexual, than if you're not on the spectrum. Very interesting statistic. And we have a ton of folks in our transgender population who are on the spectrum. We also have a lot of folks who have personality disorders because of the trauma that they suffered early in their life. And so they have a huge need for psychiatric care. And then obviously you're going to do all the other stuff that you do for everybody else in your practice. Make sure their vaccines are up to date, make sure that their lipids are controlled, make sure their blood pressure is controlled, all those things that you do for everyone. Where are the guidelines? WPATH, it's the World Organization for Transgender Health. UCSF has great resources online. Fenway Healthcare is the largest group of folks who are doing transgender research in the country. They have lots of research going on there. And so they also have great guidelines and help for taking care of our transgender patients. That's a list of all of the resources. Well, it's not all the resources that are available, but those are where some of the easy places to go. And that's all I have. Because taking care of LGBTQ folks is really there's not a lot to know. It's not that scary. Well, hello. Good. I just finished my lecture. Does anybody have questions?
Are generally like seems very complicated at first, coming in for their screening and then like getting their mammograms and their years when they're like a transgender man and maybe
Making sure that you know in your community where the safe places are to send your transgender patients. There's here in Springfield, there's one OBGYN group that we send all of our trans men to, because that's the one place that we know they're going to be treated appropriately and with respect, and they can actually get a hysterectomy. And as far as mammograms, we have not run into issues with sending folks to get mammograms at Cox. That works pretty well. As far as pap smears, most of our folks get those with us. For many of our trans men who only have sex with people assigned female at birth and are low risk for having cervical cancer, they actually do a pap on themselves, so they don't have to do the whole stirrups and all that. And there are some studies out that show that that's pretty good, and we have gotten pap smears back that are adequate pap smears on folks who do self-paps. And in the general population, it's always difficult to get people to take medicines every day. And when you're talking about folks who are on PrEP, you're looking at young people. Generally, they're more sexually active, they're more at risk, they aren't on any other medications, so taking a daily pill is difficult. We have lots of our folks who take PrEP for a long time. The new patient I saw yesterday was on PrEP in the past and stopped it, and then became HIV positive. I have another patient, young kid, mid-20s when he was diagnosed, was on PrEP, was having nausea, didn't talk to his doctor about it, so he stopped taking his PrEP and then became HIV positive. So adherence with oral PrEP, and for those folks who are at risk, who can't take oral meds, we try and get them on injectables. And the studies for the injectables, if you were assigned male at birth, injectable 60% more effective at preventing HIV. In females, people assigned female at birth, in aptitude, 90% more effective than taking oral medication, because they have to take them every day for it to be effective. So adherence, yes, is a problem. Health maintenance is a problem, but that's generalizable to all folks, and it's not specific or significantly different in folks who are transgender if they have a healthcare provider who is open and affirming of their gender.
Are there a lot of out-of-pocket costs?
We use Quest as our lab, and so PrEP labs, the HIV antigen antibody or the RNA, the syphilis and the gonorrhea and chlamydia, Quest does not charge for those for folks who are on PrEP. It's a special PrEP code. Truvada, if you have no insurance, is $15 a month cash in our pharmacy. If you have insurance, the ACA says that if you have insurance, they recommend that you pay nothing for PrEP services. So no copay for your office visit, no copay for your medications. And we do have patients who have insurance that does do that, but because it's just a recommendation in the ACA, not all insurances do that. Transgender care is not covered by Medicaid. Zero covered by Medicaid. So those patients have lots of out-of-pocket costs. Now that Liam's here, he can probably finish the lecture or answer all the questions.
I've got a rotation. You know, we should do it at least.
I'll give you your $10 in a minute.
Slowly.
Under Missouri law, we can only allow people over 18 to transition. If I treat someone under 18, that's a felony in this state. Our youngest is 5. His mom was born, his mom lived in Africa, and that's where the child was born, and they came here shortly after he was born. We've been drawing his blood since he came to the country when he was about 1.5. And then about 2 years ago, we started taking care of him in our clinic. I have a 9-year-old who lives in Poplar Bluff, who comes to us rather than going to St. Louis. And we have a new patient who's 2, 3, like that, still on liquid meds. And we just partnered with WashU, their pediatric ID group, to manage the infants who are born to HIV positive mothers. So we'll be taking on that care. Thank you all so much for paying attention. And hopefully you're not as scared as you used to be.